So when you talk about the FLT3 inhibitors, you have to talk about a number of different agents in development. So you may not know this, but FLT3 inhibitor therapy has been underway for many years now, with multiple generations of FLT3 inhibitors which have been developed all the way back into the late 2000s. So one of the first inhibitors that we developed for the treatment of FLT3 mutant AML was midostaurin. And that is what we would call a dirty inhibitor. It doesn't just inhibit FLT3, it inhibits a lot of other targets other than FLT3. Second and third generation drugs like quizartinib and most recently gilteritinib and crenolanib are much more potent, focused inhibitors that don't have the multi-tyrosine kinase inhibition that midostaurin had at its beginning. We also have learned a lot more about the treatment of FLT3 mutant AML. With the development of things like midostaurin and other FLT3 inhibitors, we've treated patients with FLT3 inhibitors for years now. And what we found is similar to BCR-ABL inhibitors, is that these leukemia cells can quickly develop resistance to one type of inhibitor. And so looking at the different types of FLT3 mutations, we've determined that some of them, specifically mutations in the D835 tyrosine kinase domain of the FLT3 kinase, can predict for resistance to certain types of FLT3 inhibitors. So for example, you mentioned midostaurin. Midostaurin has been shown to dramatically improve overall survival when added to standard 7 and 3 in the upfront treatment of AML. However, midostaurin is what we call a dirty inhibitor. However, being such a dirty inhibitor, it inhibits both D835 as well as ITD. Other inhibitors like quizartinib, which were designed to be much more potent, don't actually block D835. So we had patients in relapsed refractory AML with FLT3 mutations who had a dramatic response to quizartinib, but relapsed with disease expressing the FLT3 D835. Newer inhibitors like gilteritinib and crenolanib have the ability to block both of those types of kinase inhibitors. So unlike quizartinib, they are potent in the treatment of patients that may have failed quizartinib because of that mutation and development of kinase resistance. So we're developing a whole portfolio of different kinase inhibitors that's going to give us the option to more potently target some inhibitors and maybe to develop more of an individualized treatment regimen. So for right now, for existence, if I have a patient that has FLT3 mutant AML, I'm going to characterize what type of FLT3 mutation they have in order to determine which type of inhibitor they're most likely to respond to. So we're really moving into maybe individualized therapies for this subset of acute leukemias.